Welcome to the Sunday special on Top Med Talk. It's a potpourri of our favourite longer pieces, ideal for downloading and enjoying when you have a little bit more time. Top Med Talk.
I'm Desiree Chappell, host and managing editor of Top Med Talk. And we have the editor-in-chief of Top Med Talk, Monty Mythen. How are you, Monty?
I'm good.
The Saul Aronson. Hello, Saul. How are you?
Pleasure to be here.
Saul.
Yeah.
Well, our very special guest that's sitting down with us, I'm so excited to have her on. She runs her own mass media thing herself. It's called Brave Enough, and it's about women in medicine. And but she also happens to be the chair of the Society of Cardiovascular Anesthesiology meeting. It's Sasha Shillcutt. Hi, Sasha. How are you?
Hi, thank you so much for having me on the show. It's exciting that you all are here and supporting the annual meeting. We super appreciate it.
Well, Sasha, tell us a little bit about the meeting and kind of what went into planning and your hope for the meeting this year.
Well, we had a great program committee that put together, I think, a wonderful program that really hit on many different aspects, from innovation to kind of refresher courses to bring us up to speed, to what's going on, with mechanical devices and the future and what's going on in cardiac surgery, but also really the perioperative period for cardiovascular anesthesiologists, because we have so many people that work in the ICU now. We have people that do a lot of pain management for cardiac surgery. And so we're seeing such a growth and expansion in our clinical care that we really wanted to meet the needs of our members by providing a range of topics for nearly everyone in cardiothoracic anesthesia.
Yeah, that's fantastic. We were just talking to Jamie Ramsey, who's been a past president as well, and we were hitting on some of those highlights. And I think it's great that you are really kind of meeting the needs of so many, different providers.
And we often think of, when people think of a CT anesthesiologist, they think of someone in the operating room putting a patient on bypass, getting a patient off bypass. But I think it's so much more, as we all know, multifaceted, and we have so much diversity in our providers and how physicians are integrating with cardiologists and our surgeons and the critical care colleagues. And so we really wanted to make sure that we hit every aspect of the perioperative period for our patients and for our members so that they could go back home and feel like they actually left the meeting with some content that was applicable to their daily work life.
Yeah, that's super cool.
Sasha, my life has switched very much from being the heart component of cardiothoracic anesthesia critical care to purely thoracic component of, in particular, the critical care. So that's the lens I look at this through now. It's interesting how much we've become sort of subspecialised within a subspecialty. Do you cater for the thoracic specialists as well?
We do. We have a wonderful meeting on Friday. So before the annual meeting starts, we have an entire day just for the thoracic anesthesiologists or the cardiothoracic anesthesiologists that focus on thoracic. And then we make sure that our content on Saturday, so our workshops and hands-on things that other members can do, so it's kind of a hybrid for both of those. So we always make sure that those are on Saturday so that those who come in just for the thoracic, heavy content can go into and learn how to do transthoracic echo or learn how to do, the ECMO devices and things like that would apply more to our thoracic or our critical care folks.
Sasha, when you design the program, I know that you huddle up beforehand and you huddle up afterwards to kind of get a sense of how it's going and what you need to do going forward. What can you tell us about the sort of feedback and or focus group that the new generation of people going into this specialty are asking for moreover than in the past? And what surprises you about what they're asking for?
I think that they want discussions with the experts. That is a theme that is really evolved. So they want access to people that are publishing in our realm, people that are speaking in our realm. They want access to the experts. And it comes out in the evaluations every year that they want more small groups. They want more hands-on. They want the ability to sit down with someone like you, who's a giant in our field and who's published in
5'4",
so many amazing things. And they want to.
It's a small field.
They want to be able to have access to that. So I think one of the things that we've done is we've tried to bridge the gap from the people on the stage to the people in the audience, and we've tried to do that in numerous different ways by being innovative in how we present the data. So it's not just a panel and people in the audience, but we have multiple different ways that people, because we have different learners now, right? We have people that learn auditory, reading, and all these different ways, and hands-on. So I love that we've expanded our workshops. I love that we have expanded things like small group. We have some fireside chats. We have a lot of things that we're kind of breaking down the barrier between those people that seem so high up and the people that are just coming to the meeting to really learn.
Yeah, I love that aspect. I mean, we talk about that in the evidence-based perioperative medicine. That's where I really was first exposed to doing something different than the death by PowerPoint. We're going to do it the same every time.
But what, if I may, what's been interesting in that journey, because I hate death by PowerPoint, and I love the conversation. Whereas from a small subset, we get feedback saying, I just miss
the science.
I miss the slides.
Yeah.
Just throw more slides at me, please.
I know.
I think, how do we cater for all of them? How do we have adaptive learning?
Well, and it is a challenge. You present a really a problem that's probably a global problem in our medical education, right? Because we have people that are teaching who have a very different learning style than the people who are learning. And we have to kind of, meet in the middle. And it's interesting. I don't really know what generation I am. I'm not sure, but I'm kind of in the mix because I see both sides, So like at our board meeting, we were talking about the need to have some dynamic platform where we share documents, and half of the board was like, yeah, let's download the app. And the other half of the board was like, what? Where's the paper? We want the paper, And so it's in every, it's probably in every aspect of medicine. There's this generational, but I think that's actually really good because we need disruption. Like we need the people that have been doing this for 30 years, and we need the people that have been doing it for 3 years.
But I think what I've learned in that is that we can't judge it from the way that we see it. So there is that whole spectrum. And therefore we need to listen to everyone when they're saying, I don't like the way you did it.
Right.
Do it a different way.
Yeah. And it's interesting if you actually look at the dynamics. I've done a little bit of a deep dive into teams and how people come to a table. And the more that the people speak, are allowed to speak, the more different people are allowed to speak at a meeting. It's actually been tied to things in Fortune 500 companies, to ROI and things like that. So I think it's really good to have diversity in generation, in age, in gender, all these things, so that people come with different ideas, but they have to be allowed to speak.
And engage them.
Yes.
Yeah, that's so important. Well, Sasha, I'm really looking forward to a couple of the presentations that you're going to be doing. I know I introduced you as the creator of Brave Enough, which is this movement of women in medicine and being leaders, I guess is kind of what I've taken from it. You're an anesthesiologist, right, from the University of Nebraska, is that correct? Yeah, so you've doing that. So you are presenting during the meeting here. Can you tell us a little bit about the topics that you're going to be talking about and how that ties into kind of your personal passions? Yeah.
So one of the sessions, we're doing a plenary session, which I think is going to be fantastic, is we're doing a session on clinical burnout, and which is an epidemic, so to speak, in medicine today, and something we can't ignore. And there's been some reports and data to suggest that cardiovascular anesthesiologists and those that work in the ICU have some of the highest of all anesthesiologists. So it's a real issue that I think is complex and layered, but we want to have a discussion around it. We want to make sure that we're bringing it to the forefront for our members, and that we're hearing what they. We had a session last year that was wildly successful, and that got a ton of positive feedback. So they asked us to have another session on this, and we're doing it on Monday. And I think it's going to be really good. It's going to be conversational. It's going to be engaging. It's going to be stories of how different people express burnout. So, once I started really studying burnout and I've published on it, I recognized that, perhaps the angry surgeon he's burned out. I mean, seriously. And because men and women, physicians display burnout totally differently. Yeah. So, I mean, I now have very good relationships with our surgeons, and I can tell when they're like, and I'll say to them, like, when was the last time you went to dinner with your wife? Like, when was the last time you had like 3 days off? Like, you need to take 3 days off. I
can't let that go without passing. Men and women express burnout differently.
They do.
Please elaborate.
Yeah. So men typically, there's three major expressions of burnout. And you have to first understand that when you're burned out, it's not the same as being stressed, right? Like some stress is good. It makes us, if we didn't have some stress, we'd all be just, nothing, right?
Flight or fight.
Yeah. So burnout is this place of complete emotional and brain exhaustion where you literally disengage. So you pull back. And it is tied to poorer patient outcomes. If you can imagine, if I'm prepping the neck for a central line and I just started, I just came in 5 minutes ago, it's a lot different than when I prep the neck for a central line, after 24 hours of being in the hospital, right? So it's tied to things like higher patient infection on specific, what I call microcultures of the hospital, where certain people, this culture has a really bad burnout and turnover, and they don't have great patient outcomes versus this floor. So men typically express, they get cynical first, and they get angry. Okay.
I hope my wife's listening.
And they disengage.
I hope my wife isn't.
And they disengage. So, a lot of times I would be like, what is wrong with this surgeon I'm working with?
I totally get it.
Yeah, where women tend to emotionally get completely exhausted first. The cynicism and anger comes later. They just withdraw. They like shut down. They just shut down. So, have you ever been walking through the hospital and you see someone and you're literally like, I don't have time to smile at that person.
Yes.
I don't even have time to engage in a smile. Oh no, Monty's walking past me. What if he wants to actually stop and ask me how I am? What do? We stare at our phones. We totally disengage. We're so getting to this we're so focused. If you're like me, I know exactly what time I have to pull into the doctor's lot, to get to the Starbucks, to get to pre-op, and if somebody wants to be social, I'm like, oh no, that's not happening today, because we're very disengaged with one another. And so women tend to just emotionally shut down. They withdraw. They stop going to social events. They stop exercising. They stop doing all the things because it's a protection mode. So oftentimes people associate, which is really interesting, our leaders see that happening and they associate it with laziness. Well, here's the thing. Lazy people don't burn out.
Yeah, it's not.
It's the high achievers. So if you have a high achiever, someone who's very engaged, someone who's leading, doing a lot of great work, and then all of a sudden you start to see them kind of pulling away, that's a red flag. Or you see a guy just becoming a jerk for, he may be burned out.
Sasha, I think we kind of, all of us listening who are hopefully high achievers.
By the way, thank you. Great explanation.
Well, but to extend on that, actually, fantastic explanation. But how do we recognise that more effectively in ourselves? Because when we are burning out and someone says, do you think you should take a rest, honey? It's kind of...
Yeah, you don't want to hear that because you have how can I take a rest, right? Yeah. Most of the time when you're burned out, it's because you have a list a mile long. So the least thing that you want someone to tell you is you need to take a couple days and just,
I can't stand that.
Yeah, So one of the things that's really important is to recognize in yourself is decision fatigue.
Right.
So if you are getting to the point where you cannot it's overwhelming to make it. My husband always teases me. He's like, when I ask you what you want for dinner and you come at me you're burned out. If you cannot pick between pizza and Chinese, you may be burnt out. So
true.
You
really hit the nail on the head.
You're a redneck when. Right?
Yeah, exactly.
You're burnt out.
So one of the things to recognize in yourself is someone sends you an email and says, "Hey, Monty, would you come and speak in whatever?" That email irritates you. You don't even want to answer that email because it's maybe a good opportunity, but you have such decision fatigue and such angst and such anxiety, or you start seeing patients as you start. One of the really scary symptoms is patients just become a number. They just become a case. You completely disengage from the humanity of medicine.
So I used to recognize that when I was young, a long while ago. Maybe Sol was in the same generation. And maybe you did the same thing. On-calls would sometimes go from Friday morning, having done a full week, through Monday evening. And by Sunday afternoon, if it's been a very heavy shift, you were not thinking good things about that next patient. Now that was overt to me. I could tell. Someone let me go to sleep.
Right.
But now, how can I more effectively evaluate myself during the week and say, I wonder if?
Right.
How do I get greater awareness?
Yeah, I think the first thing to know is that your brain, you're understanding your own stress management is extremely important. So one of the things that I started when I really delved into the literature, your brain is like a puppy dog, and it's going to do everything it can to protect you. And so, for example, if you come home and you're exhausted because you've been at the hospital for 24 hours and you start getting emails on your phone, work emails because you haven't answered them in 24 hours because you've been taking care of patients, your brain is telling you you're stressed, Sasha. Go pour a glass of wine. Go eat some Doritos, whatever, which is not actually a good thing to do. Yes. But your brain is telling you, like, you're in this stress mode, just you need to be comforted, just go into this thing, which is why we have such a high incidence of substance abuse in our specialty and negative behaviors, and really in medicine why we're not healthy as physicians. So that's actually, once you recognize and you kind of change your brain to tell yourself, like, it's actually okay to be uncomfortable right now. It's okay to want to be comforted and to withdraw. I have to withdraw in a healthy behavior. That's the difference. So it's not that something, because I think a lot of times we think, what's wrong with us? Why are we stressed? Why are we burned out? I must not be a strong person. That's not it at all. It's okay to withdraw. It's okay to disengage and to kind of do something positive for yourself. But the thing is to recognize how your brain often pushes you towards a negative behavior.
When you try to balance the internal drivers to recognize and manage your own signals of dysfunction or lack of coping, help me understand, or help us better understand where the intersection between those internal signals and curing mechanisms encounter the external, if you will, forces, and how much of this, what is our limit to what we can perceive possible just from an internal point of view without having to confront the externalities of what's driving all of these things that we're talking about, and what role can we play to bend the curve from an external culture?
Right. That's a great question, because there is a kind of a conversation right now around this issue, whether it's a systems problem or whether it's individual problems. Like, is this just a millennial problem and we're just not as strong as the other generation of the millennials, or is this a systems issue with medicine and how medicine has changed? And to be less contact with patients, more contact with computers, things like that. So there's a conversation and an argument, and I would say that it's probably both of those things. There's a little bit of both of those things, but there's definitely system issues that were not present 15 to 20 years ago.
And I would add, Sasha, in particular, and maybe this is a bias, but I'll throw it out there anyway, in the area of cardiovascular anesthesiology, where we live and play, we're at the SCA, so it's appropriate to talk about this, that's a particularly challenging environment.
Mm-hmm. Yes, absolutely. And I think that, for example, I give this example. I worked, a couple months ago for 24 hours in the operating room. I did 3 cases. I went home at 6:30 in the morning. 2 cases were elective. One was an emergency. Went all night. I think I transfused 50 units of blood. I get home and I get a call. Did you scan blood number 752? I don't know. Maybe, perhaps. Well, you didn't, it was in the room, but it's not in the room, but you didn't scan it, you didn't put it in Epic, blah, blah, blah. And then I get a call, did you program the pump at 0.02 because the nurse charted it at 0.04 when you dropped the patient off in the ICU? So I'm like, okay, these are very normal things that probably have happened to all of us.
Tick, tick, tick.
Right,
tick.
but nobody logs into the EMR and it says, Sasha, you just saved this patient's life. You worked 15 hours on this person, and you know what? You delivered them to the ICU, and they're now extubated, and they're going to live from this traumatic thing. We don't get that feedback anymore, right? We don't get, and there's a breakdown too, I think, of interpersonal communication between us, because in the past, perhaps somebody would say, an older faculty, maybe my mentor would have said, hey, I heard you did this great job. I don't even see that person now. They're in another area or maybe at another hospital. So I think it has changed the way that we receive feedback for our work, and we value ourselves and others. And we have to acknowledge that.
Or you get an email that says, or a text that says one-liner, and you're like, "Are you kidding me right now?"
Yeah,
like it's too much input of everything too.
So on that subject, if I'm doing a week on intensive care, for example, the thing that I think is very different from 20 years ago is email stress.
Yeah. Mm-hmm.
In other words, my inbox is building and building and building, and even if you put an out of office like I'm kind of at it this week, please go away, I find that very stressful. Mm-hmm. That definitely contributes to my burnout syndrome at the end of the week. Mm-hmm. Are we allowed to do anything about that?
Well,
is that a real thing?
Yeah, I think it's interesting. I heard once a CEO say of a huge corporation that he has told his entire, now I don't know that we could do this in medicine, but he has told his entire, everybody knows on his executive team that he answers emails on Thursdays.
Okay.
And this is a really interesting concept because he said by Thursday, 90% of the email has already been answered. But if we did that in medicine, we would be, it's just not acceptable. And the other thing is, say I email Saul and he doesn't respond to me.
Never happened.
But he answers the phone.
And then what do I do next? I text him.
Yeah.
And if he doesn't then I go to calling, which is like a 911 anymore.
But in the meantime, you're freaking out. Does he not like me?
Yeah.
So you're trying to
exactly.
Right, yeah.
So we have this expectation of each other that I don't know that we always had in the past. It is really intense. Like you have to be available 24/7.
So two things. One is that. How do you feel this conversation is being expanded out into the world of medicine, and how are we talking? You're talking about it at this particular meeting. I know that you use social media a lot. Like, how do we talk to providers and tell them that there's the issue of burnout? We need to talk more about it.
Well, I think we can talk about it, but I think we have to really focus on solutions.
Well, that was going to be my next question.
I think that there is a lot of talk about it. The data's there. We've studied this a million times. We all know we're burned out. We all know that we have these issues. So I think really moving into what we've tried to do in our own institution is identify, because it's different for each specialty. So what stresses out us is different than what stresses out the ER guys. And, So what is one thing that we can fix this year? What is what is one area of our department that is it is just a dumpster fire that is nobody wants to do. Nobody wants to go to this area, or nobody wants to take care of these patients. Or what is the one frustration? And let's just fix it. And there's actually data to show that if you let physicians know that you're fixing one issue, they'll actually report less burnout, even if before you fixed it. Just knowing that you're going to fix it. So when leaders show that we're aware of this problem, we're hiring scribes or whatever it is for whichever division or department, there's already a deep breath, okay, help is on the horizon, or we're hiring an FTE for this, or we're changing the workflow of this, whatever it is.
Sasha, there's such an intimate relationship between cardiac surgeons and cardiac anesthesiologists. I would dare say even more so than other environments within the perioperative space, because we have such a commonality of focus and interest and content understanding. I can't imagine that the surgical world is immune to this. They're, I'm sure, having to deal with this as much as, if not more. Where could we build that bridge? How can we interdigitate to the commonality of intent to fix this now more recognized problem by having a community of surgery and anesthesia, or a community of the SCA and the STS link up and manage this in unison? Because I think it is a cultural phenomena.
I agree. I think you bring up a great point. And what we realize, you kind of heard this catchy phrase, bring your best self to work or whatever. And what people don't realize is that when you walk into an operating room with whatever issue you have, maybe you didn't get to the coffee cart, or maybe you're stressed, you're dealing with an administrative issue on your phone. You bring that stress into the operating room, which affects the surgeon, And the surgeon, she or he brings his own stress into the situation. There's an actual culture, a microculture in each operating room, between the whole team. And I think that once we realize that we have to start looking out for one another. So I always say, when you're burned out, you can withdraw from paper and projects because nobody's going to die if you don't finish a project or paper on time. But you should never withdraw from people. But that's what we do. We kind of build these walls and we become adversarial. Once you start recognizing that, like, the surgeon in the room is part of this culture and is actually affects your health, and you affect his or her health, and you become partners.
And you both affect the health of the patient.
And you both affect the health of the patient. And it doesn't have to be it's not like rocket science. It can be sharing coffee. It can be having dinners. It can be just communing with one another. It's funny how I remember going to dinner with surgeons for a search committee, and the next day I was like, I actually really liked that surgeon. They were a nice we had a conversation, and I realized, because I had no idea. I've always disliked him, but actually I really like him, because I saw him in a different light. I saw him as a human. And I think we have to do that for one another. I don't think anyone is going to save this problem but physicians. And as physician leaders and as leaders, we can't wait for some administrator, or I should say clinicians. We are going to fix this problem. It's not going to be the administration.
Well, and I have to tell you that it's not just the culture of physicians. It's the culture of healthcare, and everyone that's in that room. Just breaking it down, everyone in that room.
You're absolutely right.
However however the leaders are in the room are acting, it affects every single person. And so the nurse that's sitting there, her burnout is as severe as everyone as yours.
Absolutely. And you bring up a great point, because I think that we have to really respect that, right? Yeah. We have to, but I can also tell you that I've made a couple comments to nurses that later they've told me I was going to quit that week, but you telling me that you appreciated this little thing I did, and I didn't even think that it was a big deal. But the opposite is true. I've had surgeons tell me thank you so much. I know that was horrible. Thank you so much for sticking through this night. And that means a world of I feel like I have value that day. So even though I'm tired, I go home feeling appreciated, Yeah.
That's fantastic.
We've had lots of conversations over the years in my country about whistleblowing. Do you think it would be legitimate to have a system whereby you call out the fact that you think somebody might be burnt out?
That's a really provocative question.
Because I'm sitting here thinking, some of those leaders, administrators, managers I go to, where I'm getting this sort of trait coming back at me, I think, should there be a method where I flag up to them and say, in a non-threatening way, I think you might be burnt out.
Yeah.
I don't think you're actually as useless as I think you are.
Right.
I think you might be burnt out.
I think you're burned out, and that's why you're disengaging. And it's interesting because I can tell you, Monty, that once I started speaking on this nationally, in my own institution, people will come to my office and knock on my door. Hey, do you have 5 minutes? And shut the door and break down. And it's not women. Let me tell you, it's not all women. People think that it's people that are our highest achievers. Are our leaders, have a massive administrative duty or some other responsibility, and they don't know how to get themselves out of the position they're in. So once you actually start talking about it, we normalize the ability to call it out. So I think we lessen that kind of whistleblower, term.
I think we have to be careful because the terms or the vocabulary, vernacular we use have intrinsic sort of bias.
I agree with you.
Whistleblower is such a
we got to come up with a better word.
We got to come up with
But the principle is a sound one. In other words, you should have a mechanism whereby which you should be able to point out to somebody that they might have something they should think about, and it should be supportive.
At Duke, we have a program, and I'm just not being Duke-centric. We actually call it a cup of coffee.
Right.
And it essentially accomplishes what you just said, but it has a warmer and fuzzier connotation than whistleblower is not a good terminology.
So you're going to say that you get an email that says, I think you should drink more coffee?
No. You get an email. You get an email that says, "Can I buy you a cup of coffee?"
Oh, there you go.
Yeah.
Well, Sasha, I did want to ask. So we
now
talked about like
everybody
if
freaks
it's a
out about that
systems, if it's a systems problem, or where is this problem? Like, how personally, what are you suggesting? I mean, how do we fix this problem internally? with ourselves?
Well, I think it's different for every person how you decompress and how you process stress and how you internally reflect on where your brain is, because it's really about your head, right? It's really about like have you had a brain break? And for me, I know that I have to have 30 minutes a day. I try to get an hour. I call it my hour of power, where I decompress, I exercise, I meditate, I write. Sometimes I write in my journal. Sometimes I write just on my blog, but I have to be completely off of social media. I have to be completely disengaged with people, and it's my time. So, and sometimes I exercise, sometimes I whatever, but it's my time. And I know, I can feel if I'm not getting that, so I'm traveling or I'm on call multiple days in a row or whatever, I feel like I'm making bad decisions. I'm not making good decisions, or I don't even want to make decisions, And I'm the only person that can control that, right? So even though I think there are systems issues, it really comes up to us to say enough is enough, Well,
and how do we empower our colleagues to reach out to the people in their practices to say, like, I just need some time? Because I know, like, in the practice where I come from, I mean, there is no time. Like, you're so short staffed or whatever.
Right. And I think that it's also, we have to stop this martyrdom in medicine.
Yes.
Like, I go to the doctor's lounge and everybody's like, well, I was up for 36 hours. Well, I was up for, and it's like,
that's nothing.
Yeah. And it's like, that's not healthy. Like, I don't want you to take care of me in the mood you're in.
Yeah.
Right? So we have to actually start making it okay to take care of ourselves. So I used to hide it. Like, I used to be like, oh, I can't do that because I've got something. And now I'm like, actually, I can't do that because I'm going to go for a jog for 30 minutes or an hour. I gotta work on I gotta decompress for a while. I tell the residents that. I tell the fellows that. I model that for everybody. I don't act like important. I'm like, oh, I'm sneaking off to take care of my own mental and physical health, and I gotta hide it so everybody thinks I work hard still. Yeah. That's the wrong mentality.
It's hard though, because I mean, from the practice I came, the culture is like, you just do it, and you are weak if you have to take time.
Right.
I mean, it's just, so it's like, to me, like, I think you hit a good point, teaching our residents, teaching our fellows, teaching the people that are coming up, and modeling for them.
And also, we're so focused and driven on economics, and we have to remember that time is money. So when we tend to think, well, we can do this new program, we can do this new thing. Well, where are we going to get the funding for it? But we don't factor in our own time that it's going to cost these 7 people to invest in this program. Yeah. It's going to be added on. Like, your email doesn't go away for a week when you're taking care of patients, right? Your administrative duties don't get on pause, right? It's just, so we have to understand the cost and the tax of our own well-being when we start new things. Not that we shouldn't, but we have to factor that in. And I don't think that we often do that when we're developing new programs.
Yeah. Well, Monty, do you have one more thing?
Just to ask if you have areas that enable people to decompress at work, because I think most of ours have been taken away. They were quite, the sort of lounge areas, the quiet area, the sort of get yourself back together area.
Yeah,
they've all been converted into something else.
Well, if you look at the Mayo has done an enormous amount of work on this, and one of the things that drove this was their engagement survey. I think their physician engagement survey in 2012 was terrible. It was horrible. So one of the things they recognized is there was a direct relationship between, they had done a ton of remodeling, and they used to have areas on each floor, physician lounges, and and not just physician lounges, but areas where everybody could kind of come together. They had remodeled and gotten rid of those areas, and all of a sudden, just turnover of staffing, everything. So they just put them back, and they actually published the data to show just putting back a space for 2 people to sit down and be like, "Hey, how are you? Drink a cup of coffee and talk about patient X."
Yeah.
And humanize and connect as humans instead of on a phone or a device, increased or lowered their burnout rates.
So I love that, and I would love, and I know you're an entrepreneur at your core, to actually do an analytic and understand the calculus of what the increase in productivity, the decrease in complication, those metrics that we need to define and measure in just good economic sort of common sense. What is the return on the investment, if you will, for building space or giving, time, which has an intrinsic cost to it. But I think we have to evolve to looking at this as an analytic science of understanding what that return on that investment is with respect to our abilities to be more effective and to be more efficient. And I think it's open field running. I don't think we've done that yet well.
No, and it's interesting because I have a friend who's a family practitioner in a very busy practice, and they have a wide range of generations of physicians, and they were so burned out, they decided that they were going to work into each day an hour for each physician of downtime, whether they could exercise, and they were going to put it in the schedule. And it was a huge debate and fight. It took them a year to make this agreement. And the older generation was like, I don't want to do that. I just want to get my stuff done and go home. And the younger generation was like, I think we really need to do this. I want to be able to come to work, and if I want to go run at noon, I don't want to have those patients encroach. So they really did this. And in 1 year, everybody is so now... They still see the same amount of patients. Their productivity has gone up. Because now they're like, even the older physicians are like, love that hour because they know that they're going to have a brain break and they're going to be able to drink a cup of coffee or they're going to be able to like go for a walk outside or whatever.
So we used to have morning lists and afternoon lists in the OR in the UK.
Okay.
It was religious. You didn't start too early because it was a waste of time. Everyone would be scrabbling around. And you religiously broke for lunch. Like the whole place went quiet.
Really?
And somehow eventually it went to, based on the American model of productivity, stop all that relaxing in the middle of the day and having lunch business. Let's crack through. And let's now crack through till 7, 8 o'clock at night. Our productivity went down.
Yeah, I would envision that to be the case.
Our productivity
what
went
do
down.
the Googles of the world know that we don't?
Yeah.
Right.
And I would love for medicine as an industry to evolve and to adapt and to study the true, if you will, return on that investment of time and well-being. Something to think about.
Yes, definitely.
Well, so, Sarah, I know we have taken up a ton of time and you're so busy with the meeting. I thank you. We're so appreciative of the time that you've given us. But as Saul mentioned, you are an entrepreneur, and I mentioned that before. So tell us just very quickly about what you're doing outside of the OR and how it's kind of actually all working together.
Well, I burned out myself, and I almost quit medicine in 2013. And I was, I had a funded grant. I was publishing. I was speaking. I was on paper. I looked really good, but inside I was not good. And if you would have come to me and said, do you want to work at Lululemon tomorrow? I would have been like, yeah, great. Sign me up. And then I kept thinking why do I want to quit something that I've invested years of my life and I used to find joyful and all these things? And I realized I was very isolated. Which I'm a very strong extrovert. So the fact that I had isolated myself and I had no colleagues that I could really connect with. So I started a text group with 10 physicians, some mostly from the SCA that I knew, and said, hey, do you want to be in a text group with me where we just encourage each other and we just share with one another? Basically, I was saying, do you want to be my friend?
Yeah.
And, on the playground. Yeah. And these women said, sure, we'll be in your group. Well, my phone just kept blowing up. My husband said, if you don't get whatever's going on your phone off your phone and into some formal whatever. So then I started a group, a social networking group, and I let everybody add 2 people. So we had a group of 30, and within 2 years, there's 10,000 people in that group. And it's about really encouraging one another, normalizing the struggles of medicine, normalizing some of the things that we face, and really just being resilient and also encouraging each other to lead authentically, right? And to be brave enough, that's why I called it Brave Enough, to authentically lead as you, because so many times we lose our authenticity in medicine because we try to model a specific thing, which is what I love about this, what I love about you guys being here, and what I admire about all of you, because you're doing something outside of the normal path. And I think that's where we bring so much to the table. So I have conferences and I have courses and all these things, but it's really about connecting with others and going back into your work environment as your authentic self.
Yeah, that's fantastic. Well, any other comments? You guys have anything?
Well done.
I know, isn't this impressive?
Yeah,
So amazing.
well done.
Well done.
Thank
So
you.
impressed.
Thank you.
Yeah.
Carry on.
Yeah, absolutely.
Thank you. Thank you.
You're
very much.
doing amazing things,
Thanks.
Sasha. Thank you so much for sitting down with us, and
Yeah.
congratulations on a fantastic meeting.
Thanks so much.
It's we look forward to the rest of the time here. So thanks.
Thanks.
Cheers.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.